unmute myself. Sorry, this is all very new. So thank you very much for that. Let me just minimize it so you can see my screen. So I'm going to do a little bit of more theoretical work. I'm going to be going through the definition of children's palliative care, looking at who provides it and how we provide it. So let's have a look and see. Jan, oh dear. Sorry. Sorry, my computer's now gone and jammed. Can you hear me, Sue?
I can hear
you, Tracy. Yeah.
Sorry, yeah.
Maybe just unshare and share again.
There you go. Okay, so today the key learning points that we're going to look at are describe the meaning of palliative care, know when, how, and where palliative care can be provided, know who can provide it, and then tomorrow we're going to look at debunking the myths of palliative care, and we're going to have Melissa talking to us more about Footprints for Sam. And then on Thursday, part of the program, we're going to have a question and answer session initially for about the first half an hour, 40 minutes of the program. Any questions that you have are going to be put forward to Thursday. And then the last 20 minutes of the Thursday program, we're going to look at how to facilitate the Better Care Learning Program in your workplaces. So before we start, session 1 today, I want you to think of the word palliate or palliative care, and just quickly, if you've got a pen and paper, write down what this word means to you or what comes to mind, or you can welcome to post it on the chat group and we can have a look and see what you think. So I'm going to give you just a couple of seconds to write that down.
Great if everybody also shares it at the chat group, just some of their first ideas when they think about it.
Thank you. I can't see the chat. So.
Jennifer wrote cloak.
Thank you.
Alleviate suffering.
Okay, a few more. Let's.
Management of symptoms. Holistic and active care to improve quality of life.
Okay.
And someone said Jennifer doesn't waste her words.
Wonderful. Okay, so when we actually looked at the initial poll, there was when we asked you what you knew about palliative care, there were a lot of replies, reasonable amount of knowledge, and then a few were still learning. So you've covered quite a few of the correct definitions. So let's have a look at the word palliate. And someone did say palliate is the Latin word for palliare, to cloak or to cape. And this term was put together by, he coined it, Dr. Balfour Mount. He was a surgical oncologist in 1974. He was the person who first initially started using the word palliative care. And there are other words that come to mind too when you think of palliation, and those words include to lessen the severity of pain, disease, etc., without curing or removing, to alleviate, to surround, to comfort, to support, and to improve quality of life. And some of those did come up, but there's a lot more to what palliative care is, just what that word means. So let's look at some of the stats that are globally on children's palliative care. And this, the Global Atlas of Palliative Care released their second edition last year of 2020 of the different statistics that around the world globally, where we find palliative care, where it is. And this is just, if you have a look, where palliative care around the world, children's palliative care, the main place there where the need for palliative care is in Africa. And with this is a proportion last year. Some of the statistics have shown that this with some of the organizations have felt this is not really a true reflection of the need. But if we just look at that, it's over half of the percentage of children needing palliative care is in Africa. And then if we look at the next slide, this is broken down into the main illnesses and diseases where palliative care needs to be provided and why these children would need palliative care. And even this list is very limited to what illnesses and diseases children may have. There's a lot more, and there are places where it will say there are up to 200 different conditions or illnesses where children may need palliative care. And then if we have a look at the 29.6%, that is HIV disease still in Africa at this stage, and South Africa and globally, it's a percentage around the world that needs this. If we look at some of the stats from South Africa, so this was, UNICEF put this together, these stats together in 2012, UNICEF in conjunction with RCPCN, so it was 2013, and they estimated that there was 801,155 children in need of palliative care in South Africa. Of these 800 or so thousand, 304 and a little bit needed specialist palliative care. So the need is big. Really, we can see it's ginormous just when you look at the size of the graphs. But in fact, when this is where the real relevance comes in, out of those 800 or so, 100,000 so, there's only 14,501 children who are receiving children's palliative care at this stage. So we can see the huge need there is to provide palliative care. And this was done in 2013. We know this would have changed drastically, these numbers and these figures. And we, just by having everybody on this course and this seminar these next few days, and the response we've had just shows that healthcare professionals are becoming more open to finding how they can introduce palliative care into their places of work. Okay. So I found this in the Global Atlas as well, which was released here. Dr. Tedros Adhanom Ghebreyesus, who's the Director General of the World Health Organization, in his foreword in the manual, he said, the COVID-19 pandemic has highlighted the importance of palliative care in all healthcare systems. The need for relief from severe suffering, the difficult decision-making, and complicated grief brought on by the pandemic are exactly the types of problems that palliative care was designed to help address. And I highlighted the words, the world will be a better place when palliative care is available to all who need it. And I'm hoping you all agree with that. But the big question to ask is then, why are so few children who need palliative care not receiving it? Is it because the concept of palliative care is poorly misunderstood, or are there other reasons? Let's have a look at a couple of the reasons that we have come to think of that there isn't palliative care. Care which is offered is often fragmented and uncoordinated. There are no referral systems in place or correct referral systems in place. Even departments in hospitals are not working together. There's a lack of knowledge that goes around the importance of referrals to different organizations, different persons. And then also what we found is professionals tend to lean towards curative treatment. They've always sort of backed off from thinking that there's two ways of doing it, that we can offer palliative care with curative treatment. And then treatment and care is often disease-focused rather than being patient-centered. And last of all, one of the reasons we have noticed there are many, many myths and misconceptions about palliative care. And tomorrow we're going to have a look at those myths and hopefully we can debunk those myths and iron them out and look at the truth about what children's palliative care is about. Are there any you want to add? And I'm just going to give you a few little minutes to maybe put something into the chat room, if you can think of any other reasons. Anything coming up there? Sue, Melissa?
Fear of giving up, money, palliative care is only for some.
Very few providers.
Yes, resources. Okay, well, thank you for those answers, and please give it some more thought and just think of other reasons that there could be, and then how do we cross that bridge and change that? Okay, so the WHO definition, and it is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness, through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Then when we look at the WHO definition of children's palliative care, it reads, palliative care for children represents a special, albeit closely related field to adult palliative care. Palliative care for children is the active total care of the child's body, mind, and spirit. And it also involves giving support to the family. It begins when illness is diagnosed, and please note that the word diagnosed is in red, and continues regardless of whether or not a child receives treatment directed at the disease. And there's a really great cartoon that we use throughout training throughout the country to demonstrate how we can offer them together. Health providers must evaluate and alleviate a child's physical, psychological, and social distress. An effective palliative care requires a broad disciplinary approach that includes the family and makes use of available community resources, and it can be successfully implemented even if resources are limited. And I think that was one of the reasons when we look back and we said, why is there no children's palliative care? Is one of these is that the answer is often resources are limited. But the definition of saying we can offer it no matter how many resources or lack of resources we do have. And then it can be provided in tertiary care facilities, in community health centers, and even in children's homes. So if we look at that definition and we sum it, we would extract the main goals of palliative care. And these would be to improve and maximize quality of life, minimize pain and suffering, use a team approach, and offer support to the family. PatchSA on their website, how they explain the term palliative care, say that it is the science and art of lessening physical, psychosocial, emotional, and existential suffering by a multidisciplinary team that mobilizes existing resources. And if we look at the word science and art, I know for those of you who are professional nurses, and we talk about the art and science of nursing, and this term is also used in many, many other fields. And when we have a look at what science and art is, we think of the domains, how we learn. And when we look at what art includes, this is the affective domain. It's our area of feeling, thoughts, emotions. And these include attitudes, our values, how we care, empathy, communication, and connections. And the science aspect of it includes our knowledge, facts, and theories. And we know that is our learning area, the cognitive domain. And it's important in palliative care that this is what we need to be able to offer. This is how we provide palliative care. We need to be able to have both of these aspects and work in both domains. And one of the biggest aspects that we talk about in palliative care is communication. We need to be communicating. And so palliative care requires that it's the ability to identify and effectively react to suffering. And that word came up right in the beginning when we said, what is the word palliate? It also is the ability to meet the needs of patients and families across settings using a team approach, and the ability to listen. And when you look at what palliative requires, we see that these come from both the affective domain and the cognitive domain. But let's have a look at the word listen. And a couple of years ago, I attended a training, and I'm not sure how many of you a few of you would know Dr. David Cameron. And he used this analogy of the Chinese word for listen. And I've never forgotten it. And to me, it sort of encompasses every aspect of palliative care. So this is the symbol, and it's broken down into a whole lot of different areas. You can see these little diagrams and pictures and drawings. And I'm just going to get it up here to just see the different areas that we talk about. So the first area there that pointing is the ear. And what is an ear for? Why do we use an ear? It is to listen. The second part of the symbol is, sorry, let's go back, jump the gun here, is king. And what does a king do? Why do we talk about a king? And the king represents the person who pays attention as if the other person was the king. So that put that person first. So that leads to the aspect of patient-centered care. They are putting the person first. The next part of the symbol is the heart. And when we look at the position of the heart, we also listen with our heart. So when someone's talking to us, we are using that emotional aspect too of our heart. How does it impact us emotionally? Then the second one, the fourth symbol is one and or undivided. And when we look at either of these, the one and then the next one, the R, we look at it and we think that we listen with individual attention. We pay attention to that one person. And again, it goes back to that patient-centeredness, where we are giving individual attention to that person that we are treating. And then when we look at the R, we also be observant as if we had 10 eyes. So we're not just looking at the person with the disease, we are observing them with 10 different eyes. We're looking at them holistically, psychologically, socially, emotionally, spiritually. We're taking that all into consideration. And when you look at this word listen, you can understand why it encompasses so much of what we want to be able to offer when we offer palliative care to our patients. Sorry, I left the 10. And the 10 is giving the 10 eyes and giving full attention, 10 out of 10. With that is basically the definition of palliative care and how we provide palliative care. Of course, that is just really, really touching the surface. I'm going to show you a video now. We're going to watch a video of You Are a Bridge. And this is also just sums up what palliative care is and what role you can play.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
Okay. That's basically the definition and how we provide palliative care. And in that bridge, it talks about the different members of a team. And I just wanted to say that for the response today, we had 52 participants respond. And it's over such a broad range of professionals. And I just want to mention the different professions we do have here. There are doctors, oncologists, nephrologists, social workers, nurses, occupational therapists, physiotherapists, speech therapists, pastoral workers, and we even have some karate instructor therapists with us. So I just want to say thank you to the big team effort and the diversity of the group that we have got. And I'm going to hand over to Julia now, Dr. Julia Ambler, who's going to introduce herself, and her and Tracy Brand. And they're going to talk about hospice care for children.
Hi, everyone. I'm just getting myself unmuted and videoed. Is my screen showing?
Yep, it is.
Okay.
Hang on.
So, hi, is that okay? We can go?
Hi, everyone.
It's not, there we go. Right, so we're from Umduduzi Hospice Care for Children. Tracy is our director and social worker, and I am the doctor and deputy director. And we just wanted to have a chance today to kind of make palliative care a little bit more real. So we've done some of the theory and obviously just touching the surface, but we wanted to have a look at perhaps a little bit more about what we do and how palliative care can look in your own institution. So who is Umduduzi? Well, the word Umduduzi, those Zulu speakers in the group will know that it comes from the isiZulu meaning the comforter. Well, we're a hospital-based palliative care team. We're an NGO. We raise money every night after hours so that we can work for the government for free during the day. And we're based in eThekwini. We work in every state hospital in eThekwini, and we cover most of the private hospitals as well. We work at a lot of our work is at Nkosi Albert Luthuli Central Hospital, which serves the whole province. So we really are seeing children from most of KZN that are very ill coming to Albert Luthuli for help. And who are we? We are a doctor, a nurse, one social worker, a translator, because my Zulu and Tracy's Zulu isn't very good. And then we have two play programs that run, one at Prince Mshini Hospital in Amlazi and one at the MDR TB unit at King Dinuzulu Hospital. And those programs are there because children get bored, and palliative care takes into account a child's right to play and a child's right to education. So that's why we've included a bit of play. We'd love to have one at every hospital, but funds are obviously limited. And we receive about, on average, 250 new referrals every year. And unfortunately, many of those are actually for general palliative care. although we're a specialist service, we're seeing a lot of things that actually could have been done by a team on the ground that are already doing a lot of the work. And if they just felt more confident and understood more about palliative care, they wouldn't need us at all. Not that I'm trying to do us out of a job. So what do we mean? All sick children need some form of palliative care, every single one. So picture the scene: a child comes in with a pneumonia. They have symptoms. They might be short of breath, they're feverish, they might have chest pain. Those symptoms need to be palliated along with the antibiotics and the blood tests that are going to make the child better. And just because the child is going to get better doesn't mean they don't need some palliative care. Now, they're not necessarily needing the psychosocial support and cultural and spiritual support that is required with a more serious illness, but they still need to have their symptoms and their anxiety managed while they're a patient. And anybody in a hospital or anyone actually in a GP practice, wherever you're working, these are the kinds of things you can do if you're aware of them. On the other hand, what Tracy and I are more involved in is the more complicated cases where there are perhaps huge spiritual, psychological, emotional, cultural complexities, as well as very difficult symptoms to manage. And so that's perhaps when one would need a more experienced, specifically specialist palliative care team to go that extra mile, provide the family support perhaps at home after they've been discharged from hospital. But every single child that comes into a hospital that is unwell has some form of need for palliative care. So just want to briefly look at who are these children that we're talking about. And the Together for Short Lives is a UK advocacy organization who's done a lot of great work. It's worth looking at their website at some point. They proposed a grouping system called the ACT categories, and they have helped us to work out sort of similar groups of illnesses and the disease trajectories to help us really get into the way of thinking around an approach to palliative medicine. So there are 4 categories, and we're just going to very briefly go through them now. The first is those children who have a life-threatening illness. So these are kids that could die because of their illness or because of the treatments that are being offered to them, but there's a good chance these children are going to do really well. So the kinds of things that we see in this group might be all the leukemias, the blood cancers, other curable cancers, things like pulmonary TB, pneumonias, meningitis, when we know that there's a good chance of cure and remission, although we know that their illness is bad and actually could be the thing that ends their life. They need a lot of palliative care along with their curative care. And this is what their disease trajectory looks like. So on a graph of health versus time, you can see at the beginning that the child is quite well, they then become unwell, that's when they're diagnosed, and they go through their treatments, whether it be chemotherapy or MDR TV treatment or whatever it is. They go through their treatment and their health might vary in being good and bad during that time, but hopefully these children end up in remission. These families need a lot of support during the treatment phase, during the diagnosis phase, to come to terms and to manage while they are having to come in and out of hospital for whatever their treatment looks like. The next group, category 2, this little guy, some of you will recognize as Nkosi Johnson. He was a wonderful HIV ARV advocate, and unfortunately he never got to benefit from having ARVs himself. But these children is where a premature death is likely, but they might do well for long periods of time because there are certain treatments available. So not necessarily to remove the underlying condition, but there are treatments that they're being offered, such as ARVs, that might really help the child do well for long periods of time. So other conditions that fit into this might be cystic fibrosis. So we know now with the right antibiotics, the right physio, the right enzymes, we can support a child and the psychological support, all of that, they can do really well until their 40s. We're meeting children with cystic fibrosis these days. Other conditions, things like Duchenne's muscular dystrophy, things that we can really, when we intervene, we can't cure the underlying condition, but we can make it different. We can improve their quality of life and have them well for long periods of time. This is what their disease trajectory looks like. So they're well, they then get diagnosed and they have their complicated course of treatments up and down, and they might do well. And that the timeline down there from diagnosis to death could be, well, hopefully with HIV these days, it's approximating normal lifespan, but we don't know. The jury's still out. It's too early to say. But if a child's got Duchenne's muscular dystrophy, those children are doing better now, living to their late teens and early 20s, as opposed to dying around the age of 10 or 12. The third category, and this is where we do most of our work, these are children that have progressive conditions. They are relentlessly going to get worse over time, and the treatment is exclusively palliative. There is nothing you can do to change the outcome for these kids. So they need a lot of care and support along the way. And it's all the weird and wonderful things, or organ failure, or inoperable heart conditions, you know, the congenital anomalies, or HIV where there's no antiretrovirals available. So these kids are on a progressive path downward, and there really isn't much that can be done to change the course, but we can support them all the way through that. And this is their disease trajectory. It is absolutely relentless. And again, that time frame will depend on the underlying condition. A terminal cancer might take a few months, whereas adrenoleukodystrophy, the child might live till they're 8 or 10 years of age. And the fourth category, that is really probably one of our most tricky, this little guy is called Clement. He's one of our most famous patients because he was one of our early first patients. He's now about 18, and he's a big strapping child with cerebral palsy, a young man, I should say. And this category is where kids have irreversible but non-progressive conditions. And the difficulty with them is that they enjoy a lower level of health. They have numerous issues requiring physio, OT, speech, dietitians, in hospitals, out of hospitals, feeding problems, you name it. They have all sorts of issues that really need quite a team approach and a lot of palliative care, but they're not dying. So very often services don't want to take this group of patients on because they are chronically ill and their needs are so complex, and they hang around for years. So this group of children really does need fantastic palliative care at a hospital level because they experience so many complications. And the most obvious one is the group with cerebral palsy, but there are also those children with fetal alcohol syndrome, Down syndrome, and children that have had car accidents, or what we sadly see a lot of is TB, meningitis. I'm sure you're all aware of that. And this is their disease trajectory. It is unpredictable. They have a lower level of health generally. They might do very, very well, but they also might be admitted to hospital with recurrent pneumonias. And these kids can change category. So here you are, there's Clement. He's done extremely well. He stayed in his category. But when we were referred to him, everyone thought he was going to die. So we were thinking, actually, this is a category 3 child as opposed to a category 4 child. And what's the point of all of this? The reason is that most people that I speak to think of palliative care for cancer or for HIV, not for anybody else. And we need to change that. We need to really review who is getting palliative care, whose symptoms need controlling. And it's basically every condition that a child might get. It also helps us to make decisions on how aggressive we should be when it comes to the disease. So if a child is doing really, really well and we are hoping that we can cure them, well, then that's what we're trying to do. Our goal of care is to cure this child along with comfort measures. But if we've kind of realized that this is a child that was a category 1, so they had a life-threatening cancer, it's now relapsed, it's spread, and it's becoming a category 3 illness where the child, there's nothing we can do to fix the problem. We now need to shift our focus from cure to comfort care only, and that will help us make our plan going forward, changing gear when the time comes. So very briefly, because I know we're very short on time, just want to talk about a little girl, Hannah. I have permission from her mother to use these. She was referred to us 3 years ago. She's 8 now, and at that time she was doing quite well. She was diagnosed with an optic glioma when she was 3 years old, and she'd had surgery for it, and she'd had a shunt put in to relieve the blocked hydrocephalus and the water in the brain. But she didn't respond to oncology treatments. And we've seen a few of these kids, they just don't. On the other hand, it's an extremely slow growing tumor. So in that time, her condition hasn't deteriorated that much as one might expect. So over these 3 years, she's had really difficult physical pain to manage: headaches, neuropathic pain, pain shooting down her arms, her legs, back pain. It's really, she's had a rough time with pain. And as a specialist palliative care service, these are the drugs she's currently on, which is keeping her managed. I mean, that is a serious list of drugs. And again, we wouldn't expect everybody working in general peds to know exactly how to use all of those medications. But then not only that, we've also had to look at what are the other things, the non-pharmacological stuff that we've done for her. So we've taught her mom about distraction techniques, using guided imagery, so helping her imagine she's in a different place, some good psychotherapy counseling with our social worker, getting her mom to do stories and music therapy, massaging her. And then what does help her a lot is using a wheat bag for some heat and warmth on her neck and her back. And those things, between these two things, they've really helped. But that's not just palliative care. Palliative care goes beyond that and says, well, actually, we know that pain is not just physical. Pain comes from numerous sources. So here we go. So if we look at Hannah and her mum, there are a lot of emotional issues. So there's a lot of fear and anxiety around death and dying. Hannah knows she's not going to get better. It's been 5 years now, and she knows she's not going to get better. She's also got changing needs as she grows up. She's not 3 anymore, she's 8 now. And now with COVID, there's family conflict. The whole family are shoveled in one little place. No one's going out to work, and she can be quite badly behaved because she's bored and she's irritated and she's got pain now and again. So there is some conflict there as well. So that's the emotional stuff we need to be addressing. There are also significant spiritual issues for this family. So for Hannah, she's asked the question, is it my fault? Is God punishing me? Did I do something wrong? And then very sadly, she a couple of years ago now, I went to see her, and she said to me, Dr. Julie, are you a Christian? So I said, yes, Hannah. She said, well, I don't go to church anymore. And I said, why, Hannah? She said, because they shout at me. I said, well, why do they shout at you? Because the devil's in my head. And you just realize that her mom has been taking her to church for healing, and the pastor has been yelling and laying hands and praying that the devil comes out of her head. Then sometime after that, another few months went by, and Dr. Julia, something's bothering me in my head. I said, what is it? She said, it's the devil. Mm-hmm. You know, so there's this poor little girl who's trying to understand why the devil's in her head, why the devil's not coming out, why God is choosing not to heal her. So there's a lot of spiritual pain going on there, and that's just Hannah's. Her mother's also experiencing a whole range of spiritual pain. She also should be educated, and unfortunately she needs a special school. We found one for her, but her symptoms then suddenly progressed, and she was then too frightened to go to school, and she's point blank refused to leave the house pretty much ever since then. She's not going to school. So that makes life quite difficult for her mum. Access to play, she has had some behavioral issues. So her mum does her best, but she's not going out. She's not really socializing with friends. And one thing that Hannah can't do is share. And we have a discussion about it every time I see her, but she does not know how to share her toys. Or her sweets. She's blind, so she's very possessive over all of her things. Then there's the financial issues. We need to think about, because of COVID, the bereavement stuff. Her mum needs to be preparing for her death, but we don't know when that's coming. And then lastly, we need to think about legacy planning. Do we discuss a will with Hannah? Do we discuss what she wants for her funeral when the time comes? So that is what we would call sort of more specialist palliative care, but looking at pain, physical pain, but also the concept of total pain. What else is going on? And that is what we do in palliative care, is try and relieve the suffering in every aspect of that life. Just lastly, last slide, what about general palliative care? So if you just think about who are the kids in your care right now, who are the kids in your ward or wherever you are in Stanger or Addington or in Gauteng, you know, is it a preterm baby with a very anxious mum? Is it a toddler that has developmental delay now because of TB meningitis, cerebral palsy, heart failure, biliary atresia, acute malnutrition. What are the issues looking at mind, body, spirit, and the family that are presenting themselves that need relief, that are causing suffering? And if you can answer those questions, you are already providing palliative care. Thank you.
Thank you so much, Julia, and Tracy in the background.
Moral support.
Absolutely. You guys are both so amazing, and the work you do is incredible, and it really just opens everybody's eyes to the possibility of what can be achieved through palliative care. So I think we've got kind of 8 minutes, and I'd love to open the floor if there are any questions. But just to give an overview, so these seminars are really just an awakening to what pediatric palliative care, because everybody sitting here, whether it be Tracy, myself, Sue, the other Tracy and Julia, we have such a heart for pediatric palliative medicine, and we would love you to really open your hearts. And as Tracy said earlier, we're going to be debunking the myths. This is not about CPD points. This is about having a conversation and really just opening the door, opening the window to what PPC is and what it offers in terms of quality of life to patients. So the next few days, as Tracy said, it's debunking the myths, looking into some of the work that we all do. And then on the final day will really be the chance for conversation and to really pose questions. So to maybe give some thought to those, maybe case studies that you've got that you're struggling with, and to bring those to the panel on Thursday. But we've got a few minutes. So if we can, if anyone would like to put their hands up or ask any questions, and then we'd like to introduce you to, which we will over the next few days, to the Patch Academy, where you can earn CPD points. And it's a really beautiful online academy, and I know that you're all going to love going through it. So we just welcome you to this journey of learning and to being there as an incredible support, perhaps in a new way for some of you. But what we'd like to do is to say, don't be afraid of pediatric palliative care. It's not failure. It's not giving up. All you're doing is offering quality of life for that continuity of care when you're looking after your patients. So it really is something that you're bringing alongside clinical. It's not one or the other. It's both working together in tandem for the joy of our patients and for really to improve patient outcomes as a whole. So have we got any questions for the last few moments of the session? Not seeing.
I think just to reiterate that not to be afraid, and I presented Hannah's case because that is kind of one of the extreme cases of what palliative care can be when you're doing it as a specialist. But anything you're doing in those domains for a child, sitting with a mom, holding her hand when she's anxious, all of that forms part of palliative care, and none of that is particularly difficult. It can be emotionally hard, but that's why we're a network to support each other, because this work is hard, whether you're working in palliative care or not. Working with sick children is hard, and we should be more supportive and caring of each other. And when we do a better job palliatively and we improve quality of life, it just makes it so much better.
Jennifer, I see you got your hand up.
Hi, yes. Firstly, thank you. And hi to Julia. Haven't seen you for like 20, 25 years. So that was really nice. Just a thought about that last child. There may actually be more options available. So, I mean, I don't know this kid, but my real question is, what do you do as palliative care specialists when there's actually something curative or more invasive that could be done that would also improve quality of life? Do you have multidisciplinary team meetings? I mean, you guys can't be experts on pulmonology, cardiology, oncology, etc. But in a case like that, in our MDT meeting, we would probably have a few other options for her.
Yeah. No, thank you. It's a very good point. And I think that's one of the most daunting things for us. And Tracy goes in as a social worker, does a really good job kind of stretching her medical wings. But we don't. I Google a lot to sort of educate myself a bit more, but we certainly do that, Jennifer. We have, before we kind of start on so what we are with Hannah now, where we've got to is the decision has been made. They have offered her, they think, everything that they can. And so that's why we are where we are with her. Whereas, you know, earlier on, we take our guidance from the primary treating teams, and we're involved in lots of team meetings where we sit and we discuss, and we always ask from the child's perspective what's in the best interest of the child, because we know some of our specialists battle to let go, and they push and push and push, and you've got a family and a child saying, we've had enough, we don't want to do this anymore. So we kind of often come in as the child and family advocate in those meetings to discuss the way forward, and obviously we have to rely on the expertise of the specialists around us.
Can I just add, I think often we, just to build on what Julia was saying, is we become often the child's advocate more around stopping treatment, because often we've got people who the child's too cute, or they've grown under the treating team's skin, and there's just one more thing we can do, and there's just one more thing, and the family and the child are done. They just want out. And so we negotiate that path with the treating team. But for us, it's always about working with who the main team is and challenging them on some of their decision making. You know, who are you making that decision for? Are you making it for yourself because you're going to feel better because you've now done everything that you possibly could have done? Or are you making the decision for in the best interests of the child and the family?
I have to say, we don't see that often. We're often trying to counsel people not to carry on pursuing cure. But I mean, our field is fairly different. As you said, it's the trajectory is a lot shorter, so people have a lot shorter time to get used to it.
Yeah, and those conversations are so hard to have. And I really hope that through these discussions, we'll be able to facilitate that. And through the Better Care book, would love to, we've got a little poll just to, if there are no more questions, I'm not seeing any more hands. We've got a short poll just for people to answer before we close off. And then we look forward to seeing you all again tomorrow at 2 o'clock. So I'm hoping you've all received your Better Care books. If you haven't, please will you send a note to myself, Melissa, at footprintsforsam.org. Melissa is MELISSA, and then we can make sure that you get a book to you over the next few days. Or yeah, you should have one quite simply between all of us before the end of the next few seminar days. So thank you, and the poll will come up, and I look forward to seeing the results for that. And we'll see you all again tomorrow too. So don't sign off yet, please answer the poll, and then we look forward to seeing you tomorrow. Thanks again. Okay, I'm ending the poll of shortly. Anybody else? Thank you very much, and we'll see you guys tomorrow.